Good morning. Today's lecture will be on the topic acute necrotizing ulcerative gingivitis. So, what's the definition? Necrotizing ulcerative gingivitis is a non contagious, anaerobic, inflammatory destructive disease of the gingiva, which is associated with an overwhelming proliferation of Borrelia vincenti and fusiform bacteria presenting characteristic signs and symptoms. So Anug is also called as Vincent's disease, fusospirochetal gingivitis, trench mouth, acute ulcerative gingivitis, necrotizing gingivitis, and phage gingivitis. One of the most famous names is trench mouth. So why is it called trench mouth? It's because during World War One, the soldiers who were stationed within the trenches were seen with this disease, like affected with this disease. This could be because of the following factors. One is they were not able to maintain a proper hygiene because of intense psychological stress, sleep deprivation, and malnutrition as well. So that's why it was called as trench. Epidemiology. Anug has been documented since the 4th century BC. The most commonly affected age group is between 18 to 30 years, and children from low socioeconomic groups of underdeveloped countries are affected the most. Sometimes several members of the same family, especially in low socioeconomic groups, are affected. Types of ANOC, Penberg in 1951 classified into three forms, acute, subacute, and chronic. But chronic is a misnomer as ANOC is most of the times, as the name suggests, is in its acute condition. Etiology, Plot in 1894 and Vincent in 1896 proposed the bacterial etiology. They said that Fusiform spirochete bacterial flora was the one which is associated with the necrotizing ulcerative gingival lesions. Then, Losch and colleagues described that there could be two different types of flora which could be associated with a knock. One is a constant type of flora where there is a fusospirochetal organisms along with bacteroids, melanogenica subspecies, and there could be a variable flora where there is heterogeneous type of microorganisms present. The local predisposing factors of ANOC are pre-existing gingivitis, injury to gingiva. So when there is going to be presence of periodontal pockets or pericoronal flaps, which is going to allow for more amount of bacterial accumulation, class accumulation, it is going to predispose to another. Another important predisposing factor is injury to the gingiva. When there is going to be some kind of malocclusion, like an opposing teeth is constantly causing injury to your gingiva and making it traumatized, this can also predispose to ANOC. So, pre-existing conditions and injury are one of the most important local predisposing factors for ANOC. What are the systemic predisposing factors? Nutritional deficiency is one of the most important systemic predisposing factors, as because there's going to be a depletion of the major nutrients from the tissues when a patient is going to be malnourished for a longer period of time. So when the tissue is not going to have enough nutrients like the antioxidants, etc., which are required for defense, immunity, which are required for healing and repair of the tissues, etc., ANOG is going to happen. So that is one of the most important predisposing factors. What are the other things that can happen in nutritional deficiency is inverted T cell ratio, histaminemia, hormonal imbalance, increased level of cortisol, and defective mucosal integrity. All of this will again predispose to ANOG. Other factors that might predispose to ANOG are systemic diseases which will impair immunity, like the syphilis, cancer, gastrointestinal disorders like ulcerative colitis, blood dyscrasias like leukemias and anemias, acquired immune deficiency syndromes, nutritional deficiencies, which in long term might cause debilitating diseases. All of this might predispose to ANOG. Another important factor that might predispose to ANOG is stress. Like when a patient is stressed for a very long time, he might not be able to take care of his oral hygiene. He might not be able to have adequate nutrition because he might not be able to eat nutritious food, might enter a binge eating, might have an increased smoking levels, and might be deprived of sleep. All of this will cause depression or suppression of immunity, which will again predispose to ANOC. There is also going to be an activation of the hypothalamic pituitary adrenal axis. This in turn is going to increase the steroid and catecholamine levels of the serum, which will in turn cause microcirculation alterations of the gingiva, might cause defective activity of the neutrophils and lymphocytes, all in turn which will enhance the tissue damage. The clinical course of Anok is indefinite. So, if left untreated, it will result in necrotizing ulcerative periodontitis, which is a progressive destruction of the periodontium where there's going to be denudation of roots. This is also accompanied by an increase in severity of systemic toxic complications. Horning and Cohen in 95 staged the disease. That is, stage 1 causes necrosis of tip of the interdental papilla. Stage 2 is the necrosis of the entire papilla. Stage 3, where the necrosis extends to the gingival margin. Stage 4, where it extends up to the attached gingiva. Stage 5, up to the buccal or the labial mucosa. Stage 6, where it exposes the alveolar bone. And stage 7, where there's going to be perforation of skin and cheek. So we already saw that the young children in developing countries and in developed countries, mostly young and middle-aged adults are the mostly affected people. So Anug is going to have a sudden onset. So the interdental papilla clinically will appear red, erythematous, hemorrhagic, and a characteristic punched out crater-like necrosis, which is covered by gray pseudomembrane, is characteristic feature of Anug. Along with that, the patient is going to have fetid breath, metallic taste, excessive salivation, lymphadenopathy, fever, and malaise. So this is a sequelae of necrotizing ulcerative gingivitis. First, it is called as ANOG as long as the lesions are confined to the gingiva. When it proceeds further into deeper parts of the periodontium, causing rapid wound loss, it is going to be called acute necrotizing periodontitis. When it is going to extend beyond the alveolar mucosa with severe lesions, it is going to be called as necrotizing stomatitis. Most of the times, necrotizing stomatitis are seen in very severely systemically compromised patients. So here we see that there is stress, anxiety, which results in corticosteroid production, which results in immunosuppression. So even the presence of pre-existing gingivitis, where the areas are conducive for bacterial growth and invasion, and malnutrition, already having viral infections, protozoal infections, etc. Patients with HIV, all predisposed to ANOC, which, if severe, untreated, it goes to necrotizing ulcerative periodontitis, and even more severely systemically compromised patients, it might extend or proceed into NOMA. As far as Anug is concerned, histopathology does not provide much of relevant diagnostic information because the clinical picture is a definitive form of diagnosis. So even if we do a gram staining, we can probably see the fusospirochetal organisms like you see this spirochetes here. So that is what we can see in a histopathological slide. There are four distinct layers that could be seen in an Anug lesion, which is the superficial layer is formed of a fibrous mesh, which is composed of epithelial cells, leukocytes, bacterial cells, including rods and fusiforms and spirochetes. Next to that is a neutrophil-rich zone, which is composed of high number of leukocytes, spirochetes, and bacteria. The next lies the necrotic zone, which contains disintegrated cells and spirochetes and fusiforms, and the deepest layer contains spirochete infiltration. The differential diagnoses include hepatic gingival stomatitis, chronic periodontitis, desquamative gingivitis, streptococcal gingival stomatitis, diphtheritic and syphilitic lesions, agranulocytosis. The diagnosis is mainly based on clinical findings. Bacterial smear, of course, can corroborate with the clinical diagnosis, but it is not definitive. So how do we treat the condition? The initial treatment is debridement. So we carefully isolate the areas with cotton rolls, dry the areas. Application of topical anesthesia is done, after which the areas are gently swabbed with cotton pellets, which is saturated with hydrogen peroxide, so as to remove the pseudomembrane and the non-attached surface debris. The area is then cleansed with warm water and the superficial calculus needs to be removed. Subgingival scaling, curettage is contraindicated so as to prevent the extension of infection into deeper tissues, which might in turn cause bacteremia. If not an emergency, extractions or any kind of periodontal surgery are postponed until the patient is totally symptom free for at least a period of 4 weeks so as to minimize the exacerbation. An antibacterial mouthwash is to be given. Chlorhexidine 0.12% or a diluted hydrogen peroxide is used for this reason. A patient is advised bed rest and rinsing of the mouth every 2 hours with diluted 3% hydrogen peroxide is advised. Patients with systemic complications like lymphadenopathy, fever, malaise are prescribed with antibiotics, penicillin 500 mg 6 hourly or metronidazole 500 mg twice daily could be given for 7 days, or antibiotics could also be continued until the systemic complications subside. There has certain amount of instructions that needs to be given to the patients, like avoiding tobacco, alcohol, rinsing the mouth with equal mixture of 3% hydrogen peroxide and warm water every 2 hours, or rinsing with 0.12% chlorhexidine. Toothbrushing needs to be done carefully, which has to be confined only to the removal of surface debris with a bland dentifrice. Overzealous brushing or use of dental floss or use of dental cleaners needs to be avoided. Oral hygiene reevaluation has to be done periodically. The goal is elimination or of all the predisposing factors, whether be it local or systemic. For local, the presence of coronal flaps or periodontal pockets and kinds of local irritants all needs to be eliminated. After the patient is totally symptom free, after the healing phase, a recontouring of the gingiva can be done so as to make it conducive for the further maintenance for the patient. Persistent or recurrent necrotizing gingivitis happens mostly in patients where failure to remove the local factors is inadequate. So, care needs to be taken that a proper plaque control is done as well as it is maintained. Thank you.